Welcome, everyone. We'll begin in just a moment as we give everyone a chance to join.
Should I share my screen now, or?
No, I'll just quickly do intros in just a minute.
Thank you.
Okay. Welcome and thank you for joining us this afternoon for Northwestern's Robert J. Havey, MD Institute for Global Health webinar, Global Health Challenges During a Pandemic. My name is Jen Burke and I'm a member of Feinberg's Development and Alumni Relations team supporting the Havey Institute for Global Health. We'll begin today's event with presentations from Dr. Murphy and Dr. Havey, followed by a Q&A moderated by Dr. Ashti Prasad. If you're interested in submitting a question for our Q&A, please use the Q&A feature below. Now, I'm pleased to introduce our featured speakers for today's event, Dr. Robert Murphy and Dr. Robert Havey. Dr. Murphy is the Executive Director of the Havey Institute for Global Health, John Philip Fair Professor of Infectious Diseases, and Professor of Medicine and Biomedical Engineering at Northwestern University. His primary research and clinical interest is in viral infections. His research includes drug development of antiretroviral drugs and vaccines for HIV and viral hepatitis, and the scale-up of therapies for AIDS, tuberculosis, and malaria in sub-Saharan Africa. Some of his most recent work includes studies of surveillance metrics of SARS-CoV-2 transmission and research into the accuracy and usability of new point-of-care COVID-19 diagnostic tests. Dr. Robert Havey is the Deputy Director of the Havey Institute for Global Health, Director and founder of the Global Health Initiative Fund, and Clinical Professor of Medicine at the Feinberg School of Medicine. Dr. Havey has been in practice at Northwestern for over 35 years, where he is currently the Medical Director for Northwestern Primary and Specialty Care and a Vice President of Primary Care Operations for Northwestern Medical Group. He is a tireless advocate for global health and for the importance of primary care in all health systems. Founded in 2019, Northwestern University Feinberg School of Medicine's Havey Institute for Global Health has a mission to expand knowledge, capacity, and equity in global health through transdisciplinary research and education partnerships. Thank you, Dr. Murphy and Dr. Havey, for speaking with us today.
All right, I think I will start the program, and I'm going to share my screen now, hopefully. It worked before. Why isn't it working now? I have to try this one more time. Sorry about that. Don't know what the problem is. It says my screen is paused. I'm not sure why that is. Jen, can you use your slides, please?
Yeah, absolutely.
Great. So I'm going to start the program off today. First, welcome everyone. Thank you for joining us. I'm going to talk about the issues with the vaccines now and the future in the vaccines and future in the pandemic. Can you go forward, please? So here's the status as of today, starting with the world. This is the Johns Hopkins website, which is a great website that gives you really updates every day about what's going on. So the bottom line is there's 11.5 billion doses of vaccine have been given out worldwide. I mean, it's really incredible. 6.3, unfortunately, million deaths have occurred, and over 500 million cases reported. Since we last spoke, if you were here at any of these other ones, unfortunately, the United States is in the lead for a number of cases and also in the number of deaths that have been reported as far as countries are concerned. That hasn't changed. There's a number of reasons for that. The figures that you see on the right are the weekly case reports worldwide in the red. The white is the number of deaths that have occurred, and the green is the doses of the vaccine that have been given out per week. And you can see that the cases are now down to about the lowest levels they've been since the end of 2020. And so this seems to be the trough. We haven't really been able to get any lower than this. However, if you look at the death rate, the number of deaths, that is the lowest that it's ever been in the world. So this is actually a remarkable achievement, and it goes back to these huge numbers of people that are vaccinated. Plus, you add the immunity that has been given worldwide because of all the different people that have gotten COVID before and developed some kind of immunity. And you put those two things together, and it's having this remarkable effect on the death rate. And fortunately, the vaccines that are going out the door, either for the first time 2 doses or the boosters, is chugging along. Next slide, please. Was there another slide with the US cases? Can you go back? I think we skipped one. Yeah, this is the United States cases. The first one was the world. So in the United States, 588 million doses of vaccine have gone out, over 1 million deaths that you probably heard about last month, and a total of 85 million reported cases. And the reported cases now are way underreported because the home testing that's become available is not included in any of this. I've seen estimates up to 30 times more cases since the home test came out earlier this year than what's being reported, but it's somewhere definitely more than double. You probably heard that pretty much everybody has gotten COVID lately. It's just so common because the newer variants that are out there are incredibly contagious. So everybody's getting it. But again, if you see here in the white, these are the death rate. This is the United States data. It's down about as low as it's ever been. It's a little bit over 300 cases per day. We haven't been this low since last early summer when we were thinking that this thing could be over. And of course, it wasn't over then because then we had Delta and then we had Omicron, but now we're back down low again in terms of the number of deaths. And again, just like the worldwide situation, it's because of all the people who've had COVID and all the people who've been vaccinated. Next slide, please. This is a little bit closer, a bigger shot of the newly reported cases. But I think the important thing here is the chart on the right side of the screen, and that is the number of vaccinations. So this is, if you look at all ages, 78% of the population has actually had at least 1 dose. 67% is fully vaccinated. That's low compared to other developed countries, but still it's an awful lot of people. And then if you break it down by age, it goes up the older you are. So you look at 65 and up, they're over 95% vaccinated with at least 1 dose and 91% full doses. So this is really what's changing the game. Next. If you look at the new metrics really to look at are not the number of cases because we're not reporting them because most of them are getting diagnosed at home with a home test. But you look at hospitalizations and death. So if somebody gets hospitalized, they get a test for COVID, and that gets reported to whatever state health department that you're in. And that's because the labs have to report the test results. Same thing here with the deaths. Of course, their hospitalizations and deaths are easy to count. Even with the sort of incomplete case rate for what we are measuring, there's a 6% drop in the number of cases. So it looks like we've reached the peak of this wave and it's starting to come down. The hospitalization rate is jumped up a little bit, about 10%, but there's plenty of capacity in the system this time. The ICU rate, again, 14% jump up, but it's all starting pretty low. And the death rate is down 11%. Now remember, cases come first, hospitalization second. death, ICU admission, and then death. They'll go that way. So the death rate may pop up a little bit, but still it's very encouraging that it's going down like this, and the cases are starting to go down. Next slide. If you look overall at everybody, you can see here that about a third of the people have received a booster dose, and I'll get into the details of why that's so important. 2/3 are fully vaccinated, 78% have at least received one dose of the vaccine. So overall, there's 104 million people that have been boosted with at least one extra dose. Next. And then if you look again by age with the boosters, again, there's more older people have taken the booster compared to 18 to 64, 12 to 17, or 5. And we're soon, supposedly, maybe as early as later this week or next week, it's likely that the under 5 vaccine approval will occur. Now, if you look at the 5 to 11, they're not, very few of them are boosted and very few of them are actually vaccinated. So the uptake in the kids is very low. However, it's starting to pick up. Remember, kids get most of the vaccines that are out there. And I think this will catch on after a while, as I will deal with as we get into this presentation a little more. You look at the people who've, the green is the fully vaccinated, and the yellow on the bottom is the ones that have had the booster. And you can see that we're still lagging behind in the booster. And one of the things we can do to improve our numbers even more are to work on the booster effect. I'm consulting for several companies now that are, have changed their policies radically because of the mask mandate being lifted and whatever. And the focus now is really not just on vaccinated, but on boosted, people who've received at least one booster dose. Next. And again, you can see that when you look at the deaths, the number of deaths in vaccinated people has increased pretty dramatically from 25 to 42%. Then you look at those deaths closer, 66% of them since January, when Omicron came around, are over 75 years of age. And 75% of those deaths were in unboosted people. So it's even more important that the people at the highest risk get a booster dose. Next. And then if you look at deaths overall, still compared to unvaccinated people, even if they've had Omicron, people who've had at least their fully vaccinated 2-dose regimen, or the boosters. So the booster is the case rate per 100,000 people, 0.2 if you're a booster. It's 17 times higher if you're unboosted, 3.4. And it would be half that, like 7.5 or 8.5 times more common if they've just received the first 2 boosters. So there's still a very dramatic benefit from being boosted or being vaccinated, no matter what your age, all comers, compared to the unvaccinated group. Next. So a lot of questions come up about this second booster, and people are, let's just say there's plenty of vaccine around if anybody wants a second booster. So a couple things come up. One is the second booster is available today for virtually for most people. I think it's over 50, or if you have any underlying medical condition, actually down to age 12, if you're 88 pounds or more, or that's for Paxlovid anyway. But I mean, there's plenty of reasons why a person would want to get a booster. In the younger, healthier population, there has not been any clinical benefit seen, but remember, they're starting with a very, they're low risk to begin with. But there's 3 different studies that have looked at the second booster dose. So the second booster dose is the 4th dose. Remember, the first 2 are your first shots. Third one is your first booster. The second booster is your 4th shot. So sorry for the confusion. But the 3 groups that have looked at this the most is WHO looked at 7 studies mostly in healthcare workers. 7 are from Israel. Israel started the whole vaccine program earlier, and they have great medical records and data. So they're like months ahead of us. So it's very common that they report this earlier. One study also from Canada. This is in older people over 60. This was reported May 17th, just not even a month ago. And the 4th dose provided relative efficacy of 62% against severe COVID, so getting in the hospital. 4th dose provided even more benefit, 72% against dying, compared to not having the 4th dose. The Canadian study showed each dose increased efficacy by 82% after the 3rd dose and 92% after the 4th dose. So the studies are a little bit confusing. They're all different, and they're summarized very nicely in this WHO report, if you're interested. There was another study in Sweden, which looked at, they were having a lot of deaths in the nursing homes there, and they looked at 80-year-olds, and they gave everybody the 4th booster there. And depending on which part of the data you look at, there was a mortality benefit of 31 to 50%. I mean, it's really dramatic there. And the uptake in vaccines in Sweden is really high. The FDA, on the other hand, they approved the 2nd booster on March 29th of this year. They reviewed 700,000 patients worth of data. And because the clinical data is a little bit confusing, some of it's observational, some of it's a study, some of it's blinded, unblinded, whatever, the immunity is better and it was safe. And based on that and the little bit of clinical information they had, they approved it. So those are the 3 key things that show that the 2nd booster is beneficial. So the question I get a lot, and I'm sure Dr. Havey as well, is should I wait until the new version of the vaccine comes out in the fall? Both Moderna and Pfizer have a 2nd version that are a mixture of the original vaccine and an Omicron-based vaccine. Or should I take another booster now? And I think the answer is if you're in any kind of high risk group based on your age or any underlying medical conditions, take the booster now. Just do it now. And it's okay to mix and match. If you had Pfizer, you can take Moderna and vice versa. Pretty much we're not using the J&J vaccine anymore, except in very special instances. And the Novavax vaccine is still not approved yet. The FDA committee has reviewed it and approved it almost unanimously. There was one abstention. But now there's some issue with the manufacturing. They changed something and the FDA didn't know about it. It's approved in several countries around the world, but it's coming. If anyone has any questions about that, we can talk about it later. Next slide, excuse me. Just to give you a little snapshot of what is going on out there with all these vaccines. This is all the vaccines that are in some kind of state of being studied. 12 are approved for full use. 19 have limited use authorization. This is worldwide. 38 are in phase 3. In other words, they're ready to come out soon. And then the rest you see there are in phase 1, 2, or 3. There's all sorts of ones, intranasal ones, all sorts of ones. 15 have already been abandoned. So if you look at fully approved versus abandoned, about half of them are getting are not making it, and that's not surprising. But I'm so impressed with really how many trials are going on. 122 trials altogether are ongoing as of today. So there's a lot coming in the future. Next. And these are the top 10 or so vaccines. The Pfizer is definitely number 1. And then Moderna is the 5th. Those are the only 2 on this list at the top anyway that are used in the United States. Johnson & Johnson is mostly used in other countries. It's very little used here in the United States. And now there's a lot of restrictions on it because of the side effects associated with it. It's a great vaccine, single dose, you get pretty good benefit and whatever, but there's in women under 50 and in men over 50, there's too many side effects compared to the other ones. Next. So what's the future? My last couple of slides here. One is monkeypox. It's just more viral infections is basically what's going to happen. You're going to see crazy things like monkeypox and the adenovirus 41 that is implicated in the childhood hepatitis epidemic that's going on now. We don't even really know if that's true or not, but let's just talk about monkeypox for a second. It's a DNA virus. It's related to smallpox. The smallpox treatment and vaccines actually work. It's in animals, mostly in Central and Western Africa. Mortality rates there between 1% and 10%. The West Africa strain seems more benign, and that was the strain from Nigeria that actually ended up in the UK that kind of started the whole thing. It jumped to humans just a couple months ago, and it's mostly in men who have sex with men. And it's now spread in over 30 countries, and there's over 1,000 cases worldwide, with several thousand more under investigation, and 50 in the US, and the cases more than doubled in 1 week. So if you look at that exponential growth, you shouldn't be surprised that the United States has just ordered 300,000 doses of the Jynneos Bavarian Nordic vaccine for monkeypox. It's approved for monkeypox. It's an inactivated vaccine, very few side effects. There were 1,000 in the national stockpile, and they've just bought 36,000 doses. Then they increased the order up to 300,000 doses. They don't understand what is going on and why it's spreading so much. It's not classically a sexually transmitted infection, but anytime there's any kind of close contact, it's easy to spread, and it's been misdiagnosed as a sexually transmitted infection. But their cases are popping up all over the place, and some people have said they haven't had close contact, and is it aerosolized or not? There's a lot of issues about this, and we really don't know. I mentioned the Jynneos vaccine. There's actually, I think, 300 million doses of the ACAM 2000, which is the original smallpox vaccine that's also approved for monkeypox. However, this is the original vaccine, and many people can't take it if you're immunocompromised, if you have eczema, whatever. So it's pretty toxic. So I don't think we're going to actually get to anything like that. None of these new cases outside of Africa have resulted in death yet. There are treatments available. Tecovirimat is available, and brincidofovir is also available, but it's a pretty toxic drug. So it looks like it's really just one that's really a practical treatment. So just another strange virus infection coming along our way. And I think, if this thing keeps doubling every week, I think you're going to see some bigger action take place. Next slide. I think it's my last slide. So what is going to happen? So we basically gave up trying to control. We're the opposite of China. China still has the absolutely no COVID allowed. Things get locked down, everything stops. The United States and most of the Western countries have given up with that approach. So it's vaccinate, mitigate when necessary, and treat. And Dr. Havey is going to talk about Paxlovid, the current treatment that we have. So we want to continue the prevention, vaccinate, everyone needs to really focus on the boosters now. Get everybody boosted with 1 or 2 boosters. Expect the new vaccines to be available this fall. If you need, if you're at risk and you need to, you mitigate yourself, you wear a mask. Like now you even see on the street, probably about 10% of people in stores and stuff are wearing a mask. It probably should be higher than that. There's all different kinds of masks. We could get into how effective they are, but some kind of mask, except for the cloth mask, the surgical mask, especially if you double it up, is pretty effective. And then, so that's what we can do right now. And so what will happen? So I've studied pandemics. Every pandemic ends. The question is how and when it ends. So it's likely to, coronavirus, COVID-19, is likely to become endemic, as with influenza, which is currently, COVID is now 3 times more lethal than flu. We're down to about 300 deaths per day. Influenza is 100 deaths per day, but that's over the whole year. And influenza really only occurs about half the year. from like December till now, but it's pretty much stopping. So it's about 300 a day during the seasonal flu. COVID, as you know from what's happened, although we've had a big boost after the Christmas holidays every year, it's not seasonal. You've heard of, the summer colds and stuff. A lot of those were the other coronaviruses. It looks like COVID is not a seasonal thing, so it will come and go throughout the year. But right now, if you look at the total number of deaths, it's at least 300 per day, but it's like all year. Another issue could be, it could get worse. There's other coronaviruses, such as SARS and MERS, that are much more lethal than COVID. SARS is 10 times more lethal, and MERS is 30 times, more lethal. So let's hope that doesn't happen. So far, so good. But I think the most likely thing is that COVID will become endemic. We'll fight it with continued vaccines, treatments, Paxlovid, and other things. Bob is going to talk about that. But I think what's going to happen is we're going to find another pathogen. I don't think it's going to be monkeypox, but there's so much other stuff out there. And I think it just stresses the point that we need better surveillance around the world, and we need to be working on this really from the ground up in a global manner to figure out what's coming up next and be much more prepared for it than we are now. That is my last slide. So that ends my presentation, and I'm going to turn it over to Bob Havey right now, and he's going to give his presentation.
Great, thank you, Rob. And Jen's going to run my slides. I'm going to try not to repeat a lot of what Rob said and try to go through some general things about this pandemic and then move on to the Institute itself. So next slide, please, Jen. Next slide. So again, this will not be repeating everything Rob said, but remember that there are 7 different coronaviruses around. COVID-19 is just one of them. And when we say it will become endemic, it's going to become what we've seen with a lot of other routine respiratory infections and a lot of other coughs and colds. I've had probably 500 patients over the last 2.5 years who came in with respiratory symptoms, and we cultured them, and they had coronavirus type 4 or something, but not COVID-19. So there are plenty of coronaviruses around in the community that can get you sick. They're just not novel. So whenever you hear about COVID-19, look at that word novel coronavirus. That was the game changer on this particular virus. It was new. Nobody had any innate immunity. Nobody had any vaccines. No one had any drugs. And it's good to look at COVID-19 today and 6 months from now and a year from now and 10 years from now when you see the effort worldwide and what we've accomplished. We take it all for granted now, but 12 billion doses of vaccines. Pretty amazing that we've done what we've done in this short period of time. Next slide. This is the activity that we had in the hospital as of October of last year, which isn't that long ago, 7 months ago or so. And we had the 2 big peaks, the initial awful peak of COVID in the early part of 2020 when everybody was in lockdown. We had the summer of 2020 where we were holding our breath and hoping maybe this was a seasonal virus. And remember the days when people said the heat kills it, and it doesn't happen in the sun and all those sorts of things, which of course was all wrong, and we knew that. But then it came roaring back in the fall of 2020 and into the winter of 2021. And we had some little, we're calling them now hills and valleys throughout the summer. And by the fall of last year, we were navigating Delta, people were vaccinated, we were starting to feel pretty good about this. Next slide. And then you'll see that third big peak. This is a slide as of last week, and you can see the third mountain. So there's some mountains, some hills, some valleys, but then another big peak. And that last peak, which started in December and ran through into March, was Omicron. Settled down a little bit now, and we're into another hill, if you will. As Rob said, that hill might be settling down, but it just shows you over 2.5 years with a virus that can mutate so frequently that things are going to continue to kind of oscillate and go up and down. Next slide. Omicron was the game changer. You know, everybody thought we'd seen the worst of it. There are some theories that felt that there have been more than 100 million infections per day from Omicron. It was so contagious. Some have said that between December and now, or maybe going into the summer a little more, you could have a quarter or even half of the world infected with Omicron since it came up, because it is so contagious. And I'm sure everyone on this call has either had COVID themselves or has somebody close in their family or their friends that has struggled with this virus. So we mentioned in one of our videos 2.5 years ago that RNA viruses like COVID-19 mutate about 1% of its genetic material every 7 days. So imagine how quick that is. Once a week, this virus is morphing. It's almost like a science fiction movie. And Omicron proved that. We're into a sub-variant of Omicron right now. We still call it Omicron, but there are data that show that the Omicron of June right now is almost a completely different virus than the Omicron of December. It keeps changing and we have to keep up with it. Next slide. What do we do first? We have to test. Well, we all know that there's two main types of tests: home tests, which are being increasingly used, easy to get. Every pharmacy now has them, all sorts of different brands. And then kind of the gold standard PCR test. We're a little bit behind on the count because we don't do so many PCRs anymore because the home tests are picking this up. Sometimes it picks it up early, sometimes by day 3 or 4, but either way, more and more people are just waiting at home and doing their home tests. They're not doing the PCRs. Next slide. Everybody knows what the home test looks like. They're used to seeing the 2 lines and all of a sudden having that feeling, oh my God, I'm positive, but it's happening with regularity. Next slide. PCR is different though, and a lot of folks know what PCR, know the letters PCR, they don't know that it stands for polymerase chain reaction, and the key word of PCR is the R. It's a reaction. It's a reaction where we take one copy of a piece of the COVID gene and we make it into 2 and then 4 and then 8 and then 16, and we just keep going through these cycles. You go through 30 cycles of the machine and you've actually made 1 billion copies of this. It's like making 1 billion Xerox machines and then seeing if there's one little piece of COVID. The more cycles you go through, the less virus somebody has. So that's the reason the machine keeps cycling. Why is that important? Next slide. We've been struggling to figure out, when can people get out of jail, if you will? When are you not contagious? When can you go out and about anymore? And you would think that more lofty goals would have driven this, but the NBA drove a lot of this. They wanted to get their players back on the court. Remember, in the beginning of the pandemic, the NBA did a great job of kind of lockdown. They put everybody in the bubble in Orlando and they had a full season with no fans, but nobody got sick because they locked everyone down. Well, that was impractical over time. So now, during playoffs and regular season, they want to say, okay, we've got 3 star players who have COVID. How do we get them back on the court? Well, it used to be told that you had to go 10 days because otherwise you'd have to wear a mask on the court, which was unpractical. They started using CT, or cycle threshold. If your threshold is greater than 30, if it took that PCR machine more than 30 runs to find a little hint of virus, then you were felt no longer to be contagious to your fellow teammate and you can get back out on the field. So it's just another little novel twist on how this whole COVID conversation keeps evolving and how we make a decision over time about how do we detect it and how do we know you're okay. And then next slide, how do we treat it? Well, first we detect it with PCR, as I said, and the PCR difficulty has been that these required enormous machines that took hours to run. I had a patient tell me the other day that he had COVID 2 months ago, tested positive at home, went to a rapid place who also rapid tested him, he was positive, but they did a PCR just to be safe. He got his PCR result back in 2 months. 2 months. He got a call in the mail. It shows you how crazy some of the testing sites are out there. Some of the bad side of human nature, that some people are just profiting off of testing and not worrying about turnaround time. Turnaround time of 2 months doesn't do you much clinical good. But we clearly would like a turnaround quicker than 6 hours or 12 hours or 24 hours. Next slide. And that's where the DASH system comes in. This was a system that was originally inspired by the biomedical engineering department here at Northwestern. Funding from the Global Health Institute helped some of the initial studies on this, and now they have a machine they've actually brought to market where you can do a nasal swab, stick this in a cartridge, push this in the machine. There's this rapid cycling through this machine that can give you a PCR result in 15 minutes. Next slide. This is just another example of one of the Institute's goals, which is to try to get point of care testing around the world. Ways where more than just high-tech, high-income countries can get results that can translate into how you care for people. And the DASH is a great system of that. Next slide. So what do you do for treatment? Well, you never like to talk about treatment until you talk about prevention. And Rob did a great job on that in terms of vaccines. Don't forget masking. Everybody's assumed you don't need a mask. Masking can protect you. You just make your own decision. What's a high risk enough situation for you to feel better about yourself and the people you're around with masking. Monoclonal antibodies are very important. They are a moving target. We've been through about 6 or 7 very effective antibodies, which within literally 4 or 5 months went from being completely effective to completely ineffective because the virus mutated so quickly. So we're into drugs now, and it's still a pretty amazing thing that we've got an antiviral drug that's brought to market 2 years into the pandemic and now is widely available. And we have some other drugs, but of the outpatient drugs that can be used, Paxlovid is really the gold standard and the most effective. Next slide. Paxlovid, before we get into that, Rob talked about vaccines. We do have this debate going on. Should you take a 4-shot now or should you wait for the new hybrid? I agree with Rob. If you're high risk, the 4-shot makes sense now. Keep in mind, at the bottom of the slide I wrote down, will Omicron be yesterday's news by the fall of 22? Why is that important? It's important because the current new hybrid vaccines are putting a little piece of the original COVID mRNA into the little lipid bubble, along with a piece of Omicron mRNA. Well, what if by the time they get that to market, we're into epsilon or theta or some other Greek letter of some brand new mutation that won't be adequately covered by the new hybrid. So this is one of the challenges for the vaccine manufacturers, is that they are chasing a moving target. Next slide. This is just an example of the mRNA. Remember, we're taking a code, we're putting it into that vaccine. The devil's in the details. What code is it? So time will tell, but the great news is that even the original vaccine, although it's not preventing infection very well anymore, it's preventing severe infection and preventing hospitalization. Next slide. Keep in mind that what vaccines do is they try to get you the kind of immunity that you might get from a natural infection. And what I try to remind all my patients who come in and wonder why they have such a terrible cold from COVID, even though they're fully vaccinated, that I remind them that the main antibody in your nose and throat is immunoglobulin A, and the main antibody in your lungs is IgG. Natural infection allows you to manufacture both. Next slide. But when you have a shot in the arm, it really only stimulates production of IgG, which will protect your lungs. So this is the reason the vaccines have kept people from getting seriously ill in the hospital on a ventilator, because we have a lot of antibody the vaccine allows us to make to protect our lungs. Next slide. Someday, as Rob mentioned, there'll be intranasal vaccines. That would be a nice thing to have because it will give us mucosal protection, prevent the cold and the sore throat, and lung protection, but we're not there yet. Next slide. But we get back to Paxlovid then, because that's an oral drug that you can begin. It's indicated for people over the age of 12. You have to be at least 40 kilograms in body weight. And you have to, here's the trick here, you have to kind of guess who's at risk for moderate to severe COVID. You make a judgment on that drug in terms of who to use it on. Do you use it on the 22-year-old who's very healthy and is fully vaccinated and should get through this just fine, or do you use it on the 80-year-old? There's some clinical judgment. You'll have to work with your own doctor about this. The great thing so far is that Paxlovid has been proven to be effective against all the variants of COVID. There is some concern out there right now that after the 5-day course of Paxlovid, there might be some patients who relapse and have the disease come back. We're figuring out what that means. Remember, we learn as we go along in this pandemic. It might just mean that this virus needs to be suppressed longer so your immune system has more time to kind of stand up and keep it from coming back. Maybe 5 days isn't long enough. Next slide. Paxlovid works as a protease inhibitor. That's just one of the steps as the virus gets into our body and tries to replicate itself. And it's important to remember that the reason we brought this to market so quick is because everything stands on the shoulders of the research and discoveries that have been done before. Next slide. It was earth-shattering, really, when a chronic virus like hepatitis C all of a sudden could be absolutely cured with 12 weeks of treatment. Well, one of the treatments for hepatitis C is, in fact, a protease inhibitor. So we have had experience with hepatitis C and before that with HIV on developing ways to interrupt the life cycle of a virus. And so if it wasn't for the antiviral research and treatment of HIV and hepatitis and now COVID, we wouldn't be where we're at with drugs like Paxlovid. Next slide. So what's the conclusion about this pandemic? Well, it's here to stay. Hills and valleys, mountains, spikes and troughs, and times when you're breathing a sigh of relief and times when it's coming right back. It's not going away. The variants are going to continue. Vaccines and antiviral drugs are going to be needed long-term. There's even concerns that someday there will be resistance to protease inhibitors and we'll need new ones. We'll need different novel ways to attack this virus and others. So what do you do now? You get fully vaccinated, you get boosted to some degree. There may be some talk about whether the fourth booster is meant for everybody, but there is no disagreement that everyone should have 3 shots if you're talking about an mRNA vaccine. But also test early. If you're sick, don't wait 3 or 4 or 5 days. Drugs like Paxlovid don't really do anything if you're past 5 days of illness. If you're sick, get yourself tested early. And you isolate with the 5+5 rule, 5+5 of quarantine at home, 5 days of being back out in the world, but with a mask on. And if you're really high risk, or you can't take Paxlovid because you're on drugs that interfere with that particular drug, you can go into monoclonal antibodies, which still do work. And then in bold, I put at the bottom, we have to continue all the research and education efforts, which leads me to the next slide, which is what about the Institute itself? Oh, one last thing, I'm sorry, I forgot to mention this, is keep in mind that there's a lot of misinformation out there, and that means that work like the work of our Institute and of the over 300 members we have and all of the scientists and faculty and researchers around the country, we have to keep our work up and have our voices continue to be heard. Next slide. What's the mission of the Institute? Well, it's to educate the next generation of global health leaders. But nobody believes this when I tell them, but Murphy and I are not going to be around forever. Shocking, but probably true. And we need to continue to remember that half the world's population has really poor access to modern healthcare, and that's one of our key missions. And also, we need to accelerate our research and our scientific discoveries so that we can keep up with this pandemic and future things. Next slide. We have a lot of challenges. I won't go into all these, but one thing that has been noted is that this pandemic has probably put an extra 100 million people into poverty. We need to continue medical education of our leaders. We need to be more prepared. Next slide. The Institute itself, as a reminder, and I'll go through these quickly so we have time for questions, but we are constructed into 9 centers in one program. We do have a Center for Communicable and Emerging Infectious Diseases, which of course is the one that's gotten all the headlines lately. And it's important that we don't forget about all the other health issues in the world as we have kind of the focus on infectious diseases, and because there's lots of other things that challenge people's health, cause misery, cause poverty, and cause death. Next slide. We have to keep up with our genomics and our understanding of microbial evolution. And we've taken our pathogen genomics team, done a great job with all the sequencing of all these variants. Imagine how could we have figured out Omicron from Alpha from Delta if we didn't have talented people around the world who could just take a sample from your nose and tell you what the gene structure was. We've taken this show on the road. We've gone to other low and middle income countries as recently as last month. In fact, it shows you the risk that we take, because a couple of members of our team who traveled to Peru and Bolivia last month had to get quarantined themselves while they were away because they contracted COVID themselves while they were traveling. This is a global threat. It's everywhere. Antibiotic resistance is also something in new emerging infectious diseases. So we need to keep up with our genomics center. Next slide. We, of course, know that global primary care is critical. The Ryan Family Center is our one new funded center in the Institute, and it's dedicated to the reality that the world's population keeps exploding. We all know it. We look at the cities, we look at the news, we see this mass of people, this huge amount of people who can get sick and who need health care. Half of them don't have access to modern health care. Primary care is critical to get this done. Next slide. And our director of primary care has put out right there that it's the critical infrastructure to anchor all effective health systems. Next slide. And we do all sorts of research on this. Next slide. We have global primary care projects that we funded around the world. Next slide. And I'll go through these, just flip through these, Jen. I don't want to slow this down and show you the names, but we have done a lot of studies on this. Next slide. We have a program in global neurology, and we've had an enormous focus on long haul COVID. Our director of our global neurology program has had 242 million views in media. That's how big an interest there is in long haul COVID. And everybody who thinks that they'll just get their COVID and get it over with forgets that there are data that say that 20% of people who have COVID don't get over it in a week. They have some sort of long haul symptoms, sometimes for several months. So it's a big deal, and it's still better off to prevent it with vaccinations and treat it early when you can. Next slide. We've partnered with different partners across the globe. So when we talk about long COVID and we have these guest speakers in other countries like Nigeria talking about long COVID, they're getting the main information from the Institute here. Next slide. We have a Center for Health Policy and Economics. That seems like a little disconnect, but you can only manage well what you can measure, and you can't measure things without a good center that can look at health policy around the country, the economic implications of things, and put together plans. We've done a COVID tracker through this center. We're publishing every day on this. We're tracking COVID outbreaks in 217 countries, 7 days a week. It's an enormous effort that we've been putting forth. Next slide. And we've got innovative global health technologies, not just the DASH PCR machine I showed you, but we have a new robot that we're going to profile in this year's video of how we can do slide prep in Mali for tuberculosis, and also the establishment of biomedical engineering departments across West Africa, where those departments were non-existent before. Next slide. Global oncology is desperately needed because of all the cancer problems around the world. Next slide. We have a number of projects. You can read these quickly of all the things we're studying in global oncology. Next slide. And establishing new molecular laboratory training programs around the world, and setting up a number of studies all over the world to really look at the origins of cancer and how we can really understand a little bit more how it's caused and how we can treat it. Next slide. And we can't forget cardiovascular health, because 1 out of 3 deaths worldwide is due to cardiac problems. Next slide. And we have all sorts of projects going, from sodium project to look at dietary sodium in Nigeria. Nigeria has one of the highest high blood pressure rates in the world. Heart attack care in India. We collaborate with other emerging leaders, such as the World Heart Federation. And we put together poly pills that we're studying in other countries to treat hypertension and cholesterol. Next slide. And keep in mind that global surgery, our center is growing. We're doing great work understanding that 5 billion people don't have access to modern surgical care. I mean, imagine if you walked into one of our hospitals in the United States with something as simple as a gallbladder or appendicitis, and you couldn't get surgical care for that. And that's what's happening all over the world. Next slide. Global health education is critical. We need to educate our own students. We're happy to report that about 50% of our students who traditionally traveled to these LMIC countries are now back on the road. That's a great accomplishment. As you know, we had to shut that down during the pandemic. We have these master's and doctorate programs in global health that have been set up by Dr. Ashti Prasad. She's going to host the end of this session today. And we're training scientists in different LMIC countries around the world. Next slide. I'm going to skip through these two because we're running out of time. Next slide. Next slide. And next slide. So that's the end of my part, and we're going to have a little discussion center. But if you look at anything on all these slides, look at the middle part of this. We really do need places like the Institute for Global Health. Now more than ever, there is so much to do. You know, we talk about COVID incessantly, and I ran through the slides of our other 10 centers, but you can imagine all the work that we're doing there. It doesn't stop just because COVID's here. Our own work clinically doesn't stop. It's as if, quite frankly, we've all had, 3 full-time jobs over the last 2.5 years. It's a bit exhausting for all of us. It's a great team, though. We have more than 300 members, and I think there's a lot to be proud of what we've done and what we can continue to do, but we really do need continued support. So thank you for that, and I'll move this over to Dr. Prasad.
Thank you so much for your presentations, Dr. Murphy and Dr. Havey. And now I'd like to welcome Dr. Ashti Dubey-Prasad, who will be moderating this afternoon's Q&A. For those of you interested in submitting a question, please use the Q&A feature at the bottom. Dr. Dubey-Prasad is an associate professor of medicine in the Department of Medicine and Medical Education and the co-director of the Center for Global Health Education at the Havey Institute for Global Health. She is the founder and director of the McGaw Global Health Clinical Scholars Program for graduate medical trainees, faculty director for the online Master of Science in Global Health through the School of Professional Studies, the Global Health Elective Director, and one of the leaders in the Health and Society curriculum for Northwestern's Medical School. She is an active member in the Consortium of Universities for Global Health, where she has held leadership positions in education subcommittees and recently won the prestigious CUGH Dr. Thomas Hall, Dr. Nelson Sewankambo Mid-Career Leadership Award. Throughout her work, Dr. Dubey-Prasad has become an expert and leader in global health pedagogy, particularly ethical practice and competency-based curriculum development, and is dedicated to teaching social medicine. Welcome.
Thank you. Thank you, Dr. Murphy and Dr. Havey, for your excellent presentations. How about I start with you, Dr. Havey, since we got a lot of questions that came in, so I'm going to try to group a couple of them together. So, Dr. Havey, how does the pandemic affect access to primary care and basic preventive behaviors, both here and abroad? But you can choose to answer which part.
Well, I mean, here it's, I think the average citizen has kind of seen how we evolved. You know, in the beginning, everything was shut down, and then we went to video visits. You know, many people have said that the pandemic has kind of created the new phenomenon of telemedicine. That may be good and bad. It's helped access, but it also raises the question of what's the real role of primary care in terms of managing somebody. But we did know that the pandemic around the world really challenged primary health care systems, and vaccinations fell off, preventive care fell off, cancer screening fell off, management of lots of things fell off. So it's been difficult, but I really think that's all coming back now, and systems are back running. And fortunately, I think we kind of got through the worst of that.
Great. Thank you for that answer. So it sounds like we were really kind of suffering on a decline, and now we're maybe getting on a little bit of an uptick. I'll ask you one more question, Dr. Havey, and turn over to Dr. Murphy. So another COVID-related question is, what are the latest strategies for patients diagnosed with long COVID?
You know, long COVID is really, really difficult. The strategy, honestly, is to study it, understand it objectively, kind of document what each individual has. Because, you know, a lot of long COVID is very subjective. It's fatigue, it's brain fog, it's things like that. And it's hard to quantitate that. So Dr. Korelnik has put together an algorithm where you literally get a scoring system. But the frustrating part that we would all admit is there's no treatment. There's no treatment for long COVID. But, you know, you can only come up with treatments when you understand what you're treating. And this is kind of a new frontier, and you've got to start somewhere. So we figure we have to measure, we have to get a lot of people. You know, Korelnik now has 1,400 patients. He's studied closely with this, and he's spreading the word around the world of how to study it. So within 3 or 4 years, we're going to really know how to define it and then how to treat it. But right now, unfortunately, no great treatment for it.
Yeah, we're definitely like just at the forefront.
One thing to add to that, though, vaccinated people have less long COVID. I think that has been shown. It's not like massive, but it is less. So it's just yet another reason to stay up to date with your vaccination.
Yeah, that's perfect. So for you, Dr. Murphy, are there major global health challenges you were working on pre-pandemic that were put on the back burner? Or are some things coming back, or, you know, are there some things that you had to sort of just put on hold entirely because of the pandemic?
That's a great question. And the answer to that went 180 degrees in a different direction after the pandemic started. We really thought everything would come to a screeching halt, and that, you know, we would be way behind in all these projects that Dr. Havey outlined so clearly. And actually the opposite happened. You know, when you travel to Africa in particular, you know, it takes like a whole day to get there, a whole day to recover, and then you do whatever you're doing, and then you fly back, and, you know, whatever, however long you're there. You know, we've been working with these teams overseas for decades. We've trained them. Some of them have come here, got degrees with us, master's degrees, PhDs, specific training. And the distance meetings with Zoom and Skype and whatever actually work quite well. We actually increased our productivity. Now, shipping reagents and stuff like that, that all slowed down. But, you know, the planes never stopped, the airports never closed, the companies may have delayed their shipments and stuff, but actually we actually got a huge amount done. We've applied for grants together during the whole pandemic. The one thing that we did really lose was the student exchanges, because, I mean, they basically just came to a halt, and we hate to, you know, put a crimp in anyone's career development if they're interested in global health. But other than that, I think we actually did remarkably well. And but we couldn't have done that if we hadn't done all the work we've done over the last 20 years together.
Yeah, I agree. We had this same sort of experience with our brand new educational partnerships. We like built teams and relationships over Zoom, and then were able to implement. And it was actually really remarkable that the relationships were more about longitudinality than traveling. They're about time and not travel. But now we like hit a ceiling, and we needed to sort of get moving again. And just to sort of fill in the gap there, we did develop a lot of programs for our students to fill in those gaps so that they could be engaged virtually and do research virtually and do what we did, right? Like continue the work forward.
Yeah, I thank you for that, because you did a great job with that. Ashti runs that part of our program.
And the students really thrived. So while we have I think maybe just a bit of time left, I do want to ask you both, how has philanthropy impacted your work over the past 2 years?
Well, we have an endowed institute now, thanks to Dr. Havey's generous patience and the Ryan family, and also a new center in global primary care. And let's face it, in low and middle income countries, it is primary care. That's number one. So, I mean, that has been incredible. We have one endowed professorship in emerging infectious diseases that will finish its funding. The commitment will be done in September. We'll be recruiting a new full-time professor or associate professor in emerging infectious diseases, which is really sorely needed at this particular point. There wasn't much in emerging infectious diseases anywhere in the world until COVID hit. So, you know, you're going to see this interest in it now because we're living in a pandemic. So I don't know if that answers your question or not, but the philanthropy is critical. That's how programs, institutes, departments, and schools start and rejuvenate themselves. It's the American way. This is not the way it works around the world, but it's how it works in the United States. And
you know,
their donations
with Rob. You know, it's really hard to let folks who don't work within places like the Institute to really understand what little the 300 plus members of the Institute get personally out of this, except for great kind of intellectual and personal satisfaction that they're getting great work done and accomplishing great things, because it's a different world. This is not investment banking. It's not private equity. It's not a big return on personal investment. Folks who are in the Institute do this for the good of the mission. They really do. It's not like they're not taking home a paycheck, but nobody's got any big bucket of money to do more work. We need the support or nothing gets done. We've got 50 catalyzer projects that we funded this year. They're $25,000 a piece. That's $1.2 million of 50 different teams of researchers that put together these projects. Rob and myself and Kate Klein get together every week, and we go through another pitch from another scientist somewhere in the world that partners with someone at Northwestern, and they pitch to us what they want to do. $25,000 is a pretty small budget, but it grows into these enormous projects that then qualify for NIH funding and other sorts of grant fundings, all because the philanthropy allowed us to have this catalyzer program going. So it feeds on itself. I've given everyone, complete assurance, always have. The money is watched very carefully and it is spent very carefully, but the production is amazing what we've had done with it. So.
I agree. Thank you so much, Dr. Murphy and Dr. Havey, for answering questions and presenting. If any of our attendees are interested in learning more about the Havey Institute for Global Health or supporting our work, please visit us at globalhealth.northwestern.edu. We'll be sharing tonight's recording and slides by email after the event. And thank you again so much for joining us. And we look forward to seeing everyone again soon.
Thank you.
Thank you.